Welcome to the Deep Dive. Today, we're tackling some really big interconnected ideas. Mental health, mental illness, how we've come to understand and treat them over time, and the crucial role of emotional intelligence.
Yeah, it's a lot to unpack.
We got some comprehensive source material here. We're looking at everything from the basic definitions, what influences our mental state, to treatments, culture, even legal stuff.
Right, and emotional skills, too.
Exactly. So the mission today is really to pull out the key insights, give you a solid foundation on mental well-being and all the factors shaping it.
And our main source, it's called MH Week 1 Objectives, 1, 2, 3, 4, 5, 6, an EI PDF. It covers a really broad spectrum.
Okay.
We're talking definitions, the whole mental health continuum idea, risk factors, protective factors, resilience,
Right.
cultural influences, the nature versus nurture debate, which is always fascinating.
Always.
How society, especially in the U.S., has shaped mental health care funding issues, epidemiology, like how common things are. Then the DSM-5, psychiatric nursing, future challenges, the history of therapies, the biology behind it, psychopharmacology,
Wow. Okay.
treatment settings, cultural competence, legal and ethical angles, and finally, that introduction to emotional intelligence.
It's a huge landscape.
It is, but we'll focus on the most illuminating parts, try to make sense of it all.
Perfect. So let's start right at the beginning. Foundational stuff. What actually is mental health? And how is that different from mental illness?
Okay, so mental health, fundamentally, it's a state of well-being. It's definitely more than just not being mentally ill. It's
Right.
positive. It's when you realize your own abilities, you can cope with the normal stresses of life, you can work productively, and you can contribute to your community. It's about thriving, really, engagement.
So actively flourishing. Okay. And mental illness, then, is when that gets significantly disrupted.
Precisely, yeah. Mental illness refers to diagnosable disorders. These involve significant problems with your thinking or regulating emotions or your behavior. And these disturbances, they cause real distress or impairment in your daily functioning. It's more than just a bad day or temporary stress.
Right. Got it. Now, the material mentions a continuum. That suggests it's not just like you're either healthy or ill.
That's a really key point, yeah. They aren't just polar opposites. Think of it like a spectrum.
Okay.
At one end, you've got optimal mental health, feeling good, coping well. Then moving along, maybe you have people experiencing emotional problems or distress, but it's not quite a diagnosable illness yet. And then further along, that's where you find clinical mental illness causing moderate to severe issues.
And people can move along the spectrum. It's not fixed.
Absolutely not fixed. It's fluid. You can move back and forth. It's all influenced by this constant mix of internal things, your biology, your psychology, and external things.
Like what?
Like life events, your social situation, stress, all sorts of things.
Okay, so what might make someone, more likely to slide towards the illness end, and what helps keep people towards the healthier side?
That brings us right to risk and protective factors. Good question.
Right.
Risk factors increase your vulnerability, things like genetics, maybe a family history,
Sure.
a history of trauma or abuse is a big one, substance use. Economic hardship, like poverty, chronic physical illness can also be a risk factor. And these often interact, It's complex. Like childhood trauma might change brain development, making someone more vulnerable perhaps to substance issues later.
That makes sense. Those are serious challenges. What about the other side? What protects our mental well-being?
Okay, protective factors. These strengthen our resilience, kind of buffer us. Strong social support is huge.
Yeah.
Friends, family, community, feeling like you belong, having people to turn to.
Right.
Stable employment, education, these give structure, opportunity.
Right.
Healthy coping mechanisms are vital, how you manage stress, exercise, mindfulness, things like that. And really importantly, access to good health care. Getting help when you need it.
So having resources both inside yourself and around you. Now, resilience comes up a lot too. How does that fit in?
Resilience is basically your ability to bounce back,
Okay.
to recover from adversity, trauma, major stress. It's key for both prevention and recovery.
How so?
Well, resilient people are maybe less likely to develop a disorder even when things get tough. And if someone does experience mental illness, resilience helps them make progress, get back to well-being. It's like an inner capacity to adapt.
And can you build resilience? Or is it just something you have or don't have?
Oh, definitely. You can absolutely cultivate it. It's not just innate.
Okay, now.
Supportive relationships help build it. Learning and practicing those healthy coping strategies we mentioned, feeling empowered, having some control over your life, all these things foster resilience.
Okay, this gives us a really important framework. Now let's shift gears a bit. Let's talk about culture. It's mentioned as a powerful influence, but sometimes subtle. How does our cultural background shape how we see and experience mental health?
Culture is fundamental. It's like the lens through which we see everything, including health.
Right.
It shapes how we understand our own mental state, definitely how we express distress, what that looks like, and how we interact with healthcare. Culture influences beliefs about causes. Is it biological, spiritual, social? It dictates what's seen as normal behavior versus abnormal. And crucially, whether it's even okay to seek help.
Wow.
For example, in some cultures that are more collectivist, the family's needs might come before an individual openly expressing distress.
So something seen as a mental health issue in one place might be viewed completely differently somewhere else. Any specific examples?
Oh, absolutely. Stigma varies wildly. In some Asian cultures, for instance, admitting to depression could bring shame on the whole family.
Right.
That really discourages people from talking about it or getting treatment. Help seeking differs too. In some Hispanic or Latino communities, someone might first go to a curandero, a traditional healer. Their practices are rooted in cultural and spiritual beliefs about health, which might feel more comfortable or relevant initially.
That really highlights needing to understand different belief systems.
Yeah.
What about how distress actually shows up? Does that vary?
It can, significantly. Somatization, expressing emotional pain through physical symptoms, is more common in many non-Western cultures.
Like headaches or stomach issues?
Exactly. Someone with depression in, say, certain Middle Eastern cultures might talk more about fatigue or pain rather than sadness. Even treatment preferences differ. Western cultures often lean towards individual talk therapy. But some Native American communities might find healing ceremonies or connection to tradition more meaningful.
This just really drives home how vital it is for healthcare providers to be culturally aware. How can they navigate these nuances effectively?
Yeah, this is where cultural competence comes in. It's absolutely essential.
What does that mean practically?
It means recognizing and respecting the patient's background and actually weaving that understanding into their care. Asking sensitive questions, being aware of your own biases, that's huge, avoiding assumptions. Using interpreters if needed. Tailoring treatment plans and information to fit the patient's values.
So it might involve asking about family involvement or traditional remedies they might be using?
Precisely. It's about moving beyond a one-size-fits-all approach and seeing the individual within their cultural world.
Makes sense. Okay, let's tackle another fundamental question. The roots of psychiatric disorders. Is it mainly our genes, our nature, or is it our experiences, our nurture?
The classic nature versus nurture debate.
Right.
And the answer, as usual, is it's complicated. It's really an interaction of both.
Okay.
Nature is our biology, genetics, brain chemistry, brain structure, things we inherit. Nurture is everything, environmental life experiences, upbringing, socioeconomic factors.
And they influence each other.
Constantly. Research increasingly shows they're deeply intertwined. It's not one or the other.
So how do they actually interact to potentially lead to mental illness? Is there a model for that?
Yeah, the diathesis stress model is pretty widely accepted.
Diathesis stress.
Right. It suggests you might have an underlying vulnerability. The diathesis may be genetic for a disorder.
Okay.
But that vulnerability might just lie dormant unless it's triggered by significant environmental stress.
Ah, good.
Like trauma or ongoing adversity. It's like having a predisposition, but it needs a trigger from the environment to actually manifest, like a seed needing the right or maybe wrong conditions to grow.
That makes a lot of sense. A genetic nudge, but the environment pushes it over the edge, potentially. Now, the material also gets into social influences on mental health care, particularly in the U.S. That's a massive topic. How has society shaped care?
Oh, hugely. The history really reflects shifting social attitudes and, sadly, long periods of intense stigma.
Like the asylum era.
Exactly. People were often locked away in asylums, state hospitals. Conditions were frequently awful, inhumane. Stigma was rampant mental illness seen as weakness, danger.
Right.
Led to isolation, chronic underfunding. Then came deinstitutionalization starting mid-20th century.
What drove that?
A few things. New psychiatric medications offered hope for managing symptoms outside institutions. There was growing awareness of the terrible asylum conditions and changes in federal funding like Medicaid and Medicare. The goal was community-based care.
Sounds good in theory. But it didn't quite work out perfectly, did it? What happened?
Well, the intentions were good dignity, independence, but the community support often just wasn't there. Not enough funding for community mental health centers, not enough housing, not enough support services. So many people released from hospitals ended up homeless or in the criminal justice system.
Oh, wow.
Or cycling in and out of short hospital stays, the revolving door.
That's a really stark outcome. Are we still dealing with the fallout from that?
Absolutely. We still see major disparities in access to care.
Like what?
Racial and ethnic minorities often face higher rates of misdiagnoses, like schizophrenia diagnoses being more common in Black individuals, plus cultural and language barriers. Socioeconomic status is huge. Lower income often means more stressors and less access to affordable care. Geography matters, too. Big shortages of providers in rural areas.
So systemic barriers are still very much a reality,
Right.
even with more awareness. But the material also mentions advocacy and awareness campaigns. What role do they play?
They're critical, absolutely vital for fighting stigma. By increasing public understanding, encouraging people to seek help without shame, things like Mental Health Awareness Month, groups like NAMI, the National Alliance on Mental Illness, they do amazing work with support and education.
Right.
And when public figures share their own stories, that helps normalize it too. It all chips away at the stigma.
Bringing it out in the open seems key. Okay, let's talk money. How is mental health care funded, and how does that impact who gets care?
Funding is complex, a mix of public and private money.
Okay.
Federal and state budgets play a big role. Policies around Medicaid and Medicare are huge determinants of access. There are also laws like the Mental Health Parity Act, trying to make insurance coverage equal for mental and physical health.
Trying being the operative word sometimes.
Sometimes, yes. Enforcement and loopholes can be issues. But ultimately, policy decisions directly control how available and affordable services are.
So funding and policy really dictate access. The material also mentions epidemiology. How does that relate to mental health? We usually think of it with diseases.
Right, but it applies here too. Epidemiology studies the patterns and causes of mental health conditions in populations.
Okay.
It looks at prevalence, how many people have a condition right now, and incidence, how many new cases pop up over time.
Why is that useful?
It helps identify groups at higher risk, figure out where to put resources, and see if prevention and treatment programs are actually working. It's like mapping the mental health landscape.
Got it. And then there's the DSM-5.
Yeah.
What is that, and why is it so important in this field?
The DSM-5 Diagnostic and Statistical Manual of Mental Disorders, 5th edition, it's basically the standard guidebook used by clinicians, mainly in the U.S., to diagnose mental health conditions.
So it lists criteria.
Exactly. Specific criteria for a wide range of disorders. Clinicians use it for assessment, diagnosis, treatment planning. It's also used for insurance billing.
Okay.
It provides a common language, which is useful. But it's worth remembering, it's a human-made document, it evolves, and there are ongoing debates about its criteria and potential biases.
A necessary tool, but maybe not a perfect one. Now let's talk about the people delivering care. Psychiatric mental health nurses. What do they do?
They're specialists. You have PMH-RNs, registered nurses, providing direct care education, and PMH-APRNs, advanced practice nurses, who can assess, diagnose, treat, and often prescribe meds.
What are their core tasks?
It's really varied. Therapeutic communication is huge, building trust, crisis intervention during acute episodes, mental health promotion, trying to prevent illness, education, and advocating for patients fighting stigma, ensuring access. They're essential.
Sounds like a demanding but crucial role. Looking ahead, what are the big challenges and opportunities in U.S. mental health care?
It's a mix, definitely. Big challenges include provider shortages, especially in certain specialties and areas.
Right.
Rising rates of some conditions, like anxiety and depression, especially post-pandemic. Ongoing inequities in access. And stigma, always stigma.
Still a barrier. What about opportunities? Any bright spots?
Yes, definitely. Telepsychiatry is a huge one, expanding access, especially remotely.
I've seen that grow.
There's a momentum for policy changes to improve insurance parity and funding. Integration with primary care is promising, catching issues earlier. And advances in genetics and neuroscience might lead to more personalized treatments down the road.
So challenges remain, but there's potential for positive change. Okay, let's shift focus slightly and look at how our understanding and treatment approaches have evolved.
Yep.
It wasn't always like it is now, right?
Oh, not at all. The history is fascinating and sometimes disturbing. Early explanations often involved, demonic possession or supernatural forces.
Right.
Then came the psychodynamic era, Freud, unconscious conflicts. Mid-20th century saw behavioral approaches, learning, conditioning, and humanistic approaches, self-actualization, personal growth.
Okay.
More recently, the biological model gained prominence focusing on the brain, neurotransmitters. And today, the biopsychosocial model is widely accepted.
Biopsychosocial.
Yeah, it integrates biological factors, psychological factors, and social environmental factors. Recognizes it's usually a mix of all three.
A more holistic view.
Yeah.
And these different ways of thinking led to different therapies.
Exactly. Psychodynamic theory led to therapies focused on insight into the unconscious. Behavioral theories gave us things like behavior modification, exposure therapy for anxiety.
Right, like CBT?
Well, cognitive behavioral therapy, CBT, came from cognitive theory, which emphasizes how thoughts influence feelings and behaviors. So CBT focuses on changing unhelpful thought patterns.
Okay.
Humanistic theories led to client-centered therapy, empathy, positive regard. Biological theories underpin medication treatments, ECT. Interpersonal theory focuses on relationships. Clinicians often blend these approaches now.
A whole toolkit. How do psychiatric nurses use these different theories in their daily work?
They integrate them constantly. CBT principles help patients challenge negative thoughts. Behavioral techniques reinforce positive habits. Interpersonal skills are core to building the therapeutic relationship. Peplaw's model is big here.
Right, Peplau.
The biological understanding informs medication management. Developmental theories help tailor care to different age groups. It's all woven together.
You mentioned Peplau's theory as being influential. Can you expand on that a bit?
Sure. Hildegard Peplau's theory is really foundational for psychiatric nursing. It emphasizes the nurse-patient relationship as the main tool for healing.
Yeah.
She described phases of the relationship orientation, working, etc., and different roles the nurse takes: teacher, counselor, resource. The focus is on collaboration, empathy, self-awareness by the nurse, helping the patient grow and develop coping skills.
Sounds very patient-centered. Now, going back to the biological model, what's been its biggest impact?
Medications, definitely.
Yeah.
Psychotropic drugs targeting neurotransmitters have transformed treatment for many.
Sure.
Also, advanced biological treatments like ECT or TMS for severe cases. Brain imaging helps us understand the brain's role. And importantly, framing mental illness as a medical condition has helped reduce some stigma, though not eliminated it.
That perspective shift is huge.
Yeah.
And briefly, developmental theories, Erickson, Piaget, how do they help nurses?
They help nurses understand what's typical behavior for different ages.
Okay.
Knowing Erickson's stages, like identity versus role confusion in teens, helps tailor support. Piaget's stages of cognitive development inform how you communicate and explain things. It ensures care is age-appropriate and sensitive to developmental tasks.
So different lenses for different aspects of care.
Fascinating.
Okay, let's dive even deeper into the biology, psychobiology, and pharmacology. What key brain areas are involved in mental health?
Several key areas. The frontal lobe executive functions, planning, judgment, often implicated in things like schizophrenia or ADHD.
Right.
The temporal lobe hearing, memory, emotion processing, relevant in psychosis, dementia. The limbic system, deep structures like the amygdala, hippocampus, crucial for emotion, memory. Big players in mood and anxiety disorders. Basal ganglia movement, but also emotion, habits. Brainstem for basic functions. Hypothalamus links to hormones. Research is constantly refining how these areas connect to specific disorders.
So different brain regions handle different jobs, and problems can arise when they aren't functioning typically. How do medications fit into this? How do they work?
Psychotropic meds mainly work by influencing neurotransmitters.
The chemical messengers.
Exactly. They can change the levels of these chemicals in the synapse, the gap between nerve cells, or affect how they bind to receptors or how they're cleared away. Basically, they adjust the chemical signaling to try and alleviate symptoms.
And which neurotransmitters are the main targets?
Some key ones are serotonin, heavily involved in mood, sleep, appetite. Low levels, often linked to depression.
Right, SSRIs target that.
Correct. Dopamine motivation, reward, attention, movement. Imbalances linked to schizophrenia, Parkinson's, ADHD. GABA, the main inhibitory, calming neurotransmitter, often targeted by anti-anxiety meds.
Right.
Norepinephrine alertness, stress response, mood. Also implicated in depression and anxiety. Glutamate is the main excitatory one. It's a complex interplay.
It really sounds like it. Can we actually see differences in brain activity related to mental illness?
Sometimes, yes, with brain imaging. CT and MRI show brain structure.
Okay.
Functional MRI, or fMRI, shows activity by tracking blood flow. PET and SPECT scans can look at metabolism or receptor activity.
Are these used for diagnosis regularly?
Mostly in research right now to understand the disorders better. They can sometimes help rule out other causes or occasionally inform treatment, but they aren't routine diagnostic tools for most conditions yet.
Got it. Now, the material mentions pharmacodynamics and pharmacokinetics. What's the difference? Sounds technical.
They are a bit technical, but crucial. Pharmacodynamics is what the drug does to the body.
Its effects.
Yes. How it affects neurotransmitters, receptors, the therapeutic effects, the side effects. Pharmacokinetics is what the body does to the drug.
How it processes it.
Exactly. Absorption, distribution, metabolism, excretion, ADME. How it gets in, where it goes, how it's broken down, how it gets out. You need to understand both to use meds safely and effectively.
Right. Makes sense. So different drug classes hit different neurotransmitters, like antidepressants.
Generally, yes. Antidepressants often increase serotonin, norepinephrine, or dopamine. Anti-anxiety meds frequently enhance GABA.
Okay.
Mood stabilizers work on various pathways, sometimes involving glutamate or GABA. Antipsychotics usually block dopamine receptors. Stimulants boost dopamine and norepinephrine. Cholinesterase inhibitors used for dementia increase acetylcholine.
It's all about tweaking that brain chemistry. What about herbal treatments? People often ask about things like St. John's wort.
Yeah, it's important to be cautious. Herbal remedies can interact with prescription meds, sometimes dangerously, like St. John's wort and SSRIs can cause serotonin syndrome.
Wow, okay.
They aren't regulated like drugs, so potency and purity vary. Using them might delay someone getting evidence-based care. And they can have side effects, too. Patients really need to tell their doctors about everything they're taking, including herbals and supplements.
Crucial advice. Okay, understanding the biology is key.
Yeah.
Let's move to where treatment happens, the settings. What makes it hard for people to even get access to care in the first place?
Oh, lots of barriers. Stigma is still a huge one, fear of judgment.
Yeah.
Financial issues, cost of care, lack of good insurance, shortages of providers, especially psychiatrists, especially in rural areas.
Right.
The system can be fragmented mental health care separate from physical health care. Practical things, too, like getting time off work, transportation, childcare, it all adds up.
A lot of hurdles. If someone does get into care, what kinds of settings are there?
There's a whole continuum. Basic outpatient therapy, maybe weekly sessions. More intensive outpatient IOPs, several times a week. Partial hospitalization. PHP, structured treatment during the day, go home at night. Full inpatient hospitalization for acute crises or safety concerns. And long-term residential care for severe chronic conditions needing 247 support.
So it depends on the level of need.
Yeah.
How is that decided? And what's the role of a regular doctor versus a specialist here?
Often the primary care physician, the PCP, is the first stop. They can do initial screening, maybe prescribe some basic meds for anxiety or depression. But for more complex diagnoses, specialized therapies, or medication management, that's where mental health specialists come in. Psychiatrists, psychologists, psychiatric NPs, therapists. Ideally, the PCP and specialists collaborate.
That integrated care idea again. Material mentions patient-centered medical homes, PCMHs.
Yeah.
How they fit in.
PCMHs are a model trying to make that integration happen. It's team-based, patient-focused care.
Okay.
They coordinate all patients' care, mental, physical, social needs. It helps communication between providers, aims for more holistic, accessible care.
Sounds like a good goal. What about community options like psychiatric home care or ACT teams?
Psychiatric home care is when a nurse provides services in the patient's home med management, teaching, support, helps reduce hospital readmissions.
Right.
ACT assertive community treatment is really intensive. It's a team approach for people with severe mental illness, providing 24/7 support right in the community, helping them manage symptoms and live independently. High-level support.
Got it. And partial hospitalization, PHPs, where do they fit?
PHPs are like a bridge. They offer intensive, structured daytime treatment, more than typical outpatient, but less than full inpatient. Good step down from the hospital or step up if outpatient isn't enough.
Makes sense. And technology. Telepsychiatry.
Huge impact. Using video calls, phone calls to deliver therapy, manage meds, it's dramatically increased access, especially for people in remote areas or those with mobility issues or transportation barriers.
Breaking down barriers. So what's a nurse typically doing in these outpatient settings?
A lot. Assessments, triage, maybe therapy if they have the training, medication management and education, crisis intervention if needed, case management linking patients to resources, and lots of collaboration with the team.
Busy role.
Huh.
What about inpatient? What kinds of units are there, and what rights do patients have when they're hospitalized?
Inpatient includes acute care units for short-term crisis stabilization, state hospitals for longer-term severe illness, forensic units for those in the legal system, and sometimes psychiatric units within general hospitals.
All right.
Patients have significant rights, even if hospitalized involuntarily sometimes. The right to treatment, the right to refuse treatment unless they lack capacity or are in immediate danger.
Right.
The right to informed consent, privacy, communication, a safe environment. These are legally protected.
Really important protections. The term therapeutic milieu comes up for inpatient. What is that?
The milieu is the overall environment on the unit. It's intentionally designed to be therapeutic. Structured routines, safety protocols, clear expectations, patient involvement in the community, supportive staff interactions, group activities. It's about creating a safe, structured, supportive space that promotes healing.
Like a healing community within the hospital walls? And the nurse's role in that?
Central. Nurses manage the milieu day to day. They do admissions, ongoing assessments, ensure safety, administer meds, facilitate groups, de-escalate situations, support patient rights, and plan for discharge back to the community.
Nurses really are at the heart of it, across all settings. Okay, let's circle back to culture. We talked about its general influence, but how does it specifically impact delivering mental health services?
It's critical. As diversity increases, providing culturally relevant care isn't just nice, it's necessary for effective treatment.
Why?
It builds trust, improves communication, increases the chance someone will stick with treatment, leads to better outcomes. It helps reduce health disparities, and it simply respects the person's beliefs and acknowledges how culture shapes their experience.
So ignoring culture can actually harm the therapeutic process.
Right.
What are challenges when Western methods meet different cultural backgrounds?
Western models often emphasize individualism, direct verbal communication. That might clash with collectivistic cultures or those where communication is more indirect.
Right.
Diagnostic tools developed in the West might not capture culturally specific ways of expressing distress, like somatization we mentioned, risk of misinterpreting culturally normal behavior as illness, and language barriers are always a potential issue.
Can you give examples of how Western nursing assumptions might clash with other views?
Sure. Western care values individual autonomy highly. Many other cultures stress family input in decisions.
Okay.
Western focus is often biological causes. Others might see spiritual imbalance. Western therapy relies on talking openly. Other cultures might value silence or indirectness. Medication is primary in the West. Traditional healers might be preferred elsewhere.
Big differences. What specific barriers stop people from diverse backgrounds getting good care?
Stigma. Often culturally specific stigma, language barriers, mistrust of the healthcare system, maybe due to past discrimination, lack of culturally competent providers who understand their background, different beliefs about illness and treatment, access issues like cost or location.
Are there specific groups within diverse populations who are particularly at risk or face unique challenges?
Yes. Immigrants might face stress related to acculturation, fitting into a new society. Refugees often carry significant trauma. Cultural minorities may face added burdens from poverty, systemic racism, and discrimination, impacting both mental health and access to care.
So, knowing all this, how can providers do better? How can they conduct culturally sensitive assessments and make care plans that actually work for diverse individuals?
It starts with humility and curiosity. Use professional interpreters, not family members if possible.
Right.
Explore the patient's own understanding of their problem. What do they call it? What do they think caused it? Ask about traditional healing practices they might use or trust. Assess for barriers like stigma. Use open-ended questions.
And the care plan.
Integrate their preferences. Involve family if that's culturally appropriate and the patient consents. Respect traditional practices if they're safe and don't interfere with treatment. Collaborate with traditional healers if possible and appropriate. Tailor education materials.
It sounds like a partnership. The material lists cultural competence constructs. What are those?
It's a framework for developing competence. Includes cultural awareness, knowing your own biases, cultural knowledge, learning about different cultures, cultural encounters, interacting respectfully with diverse people, cultural skill, adapting your assessment and care, and cultural desire, genuinely wanting to provide culturally sensitive care. It's an ongoing journey.
Continuous process. Okay, let's switch to the legal and ethical side. Big area. First, ethics versus bioethics.
Ethics is the broad study of morality, right and wrong. Bioethics applies those ethical principles specifically to healthcare situations and dilemmas.
Got it. What are the core principles in bioethics?
There are several key ones: beneficence, acting to benefit the patient, doing good; autonomy, respecting the patient's right to make their own decisions; justice, fairness, distributing resources and care equitably; fidelity, being loyal, keeping promises, being trustworthy; veracity, telling the truth; and non-maleficence, the duty to do no harm.
That's a solid ethical foundation. Now, legally, how do admissions and discharges work in psychiatric settings?
Admissions can be voluntary, the patient agrees to come in, or involuntary, also called commitment.
Right.
Involuntary admission happens through a legal process if someone is deemed a danger to themselves or others, or gravely disabled and unable to care for themselves. It involves strict legal safeguards.
Okay.
And discharge can be a regular discharge when stable. Conditional release might require outpatient follow-up. Unconditional release means no strings attached. Or AMA against medical advice when a patient leaves, even though the team recommends staying.
So legal processes are involved, especially with involuntary care. We touched on patient rights before, but can you recap the main ones in the hospital?
Key rights include the right to receive treatment, the right to refuse treatment, again, with exceptions for immediate danger or lack of capacity, the right to informed consent understanding treatment before agreeing.
Crucial.
Right to privacy and confidentiality, HIPA. Right to communicate with people outside. Right to a safe environment free from abuse or neglect.
These rights are vital. What about restraint and seclusion? They sound like serious interventions. What are the rules?
Extremely serious. They are absolutely last resorts, only used for immediate risk of harm to self or others when less restrictive methods fail.
Okay.
Requires a specific doctor's order, strict time limits, continuous monitoring, careful documentation of why it was needed and how long it lasted. The goal is always to release the person as soon as it's safe.
Highly regulated. What about confidentiality? How absolute is it in mental health? Are there exceptions?
Confidentiality is fundamental, protected by High Queer, but it's not absolute. Key exceptions include the duty to warn potential victims if a patient makes a credible threat, the Tarasoff rule. Reporting suspected child or elder abuse is mandatory. Reporting certain communicable diseases, and responding to court orders.
So safety and legal mandates can override confidentiality sometimes. What are some other key legal terms nurses need to know?
Understanding the law itself. Torts, civil wrongs like negligence or malpractice. Negligence is failing to provide the expected standard of care, causing harm. Malpractice is professional negligence.
Right.
Also important are professional standards defined by state nurse practice acts, professional organizations like the ANA and their codes of ethics, institutional policies, and customary practice. These set the expected standard of care.
What should a nurse do if they see something wrong, negligence, or illegal activity?
They have a duty to act. Report it following the facility's chain of command. Document everything factually, objectively, and thoroughly. Don't gossip or speculate, just state facts.
Documentation again.
Yeah.
Why is it so critical legally and ethically?
It's the legal record of the care provided. It protects the nurse and the institution if questions arise. It ensures continuity of care. It needs to be accurate, timely, objective, and detailed. If it wasn't documented legally, it didn't happen.
That's a powerful reminder. Lastly, on legal, what about violence against healthcare workers? Are there protections?
Yes. Sadly, it's a risk. There are laws against assault. Workplaces should have violence prevention programs, training, reporting procedures. It's crucial to report all incidents.
Good to know those protections exist.
Mm.
Okay, final major topic. Emotional intelligence, or EI. What exactly is it?
Emotional intelligence, basically it's about being smart with emotions your own and other people's.
Okay.
It's the ability to perceive emotions, to understand them, to manage them effectively, and to use that understanding to guide your thinking and actions. Crucial for navigating social situations, leadership, making good decisions, building relationships.
So emotional awareness and skill. Goleman's model has 5 components.
Right. Daniel Goleman popularized it. His 5 components are self-awareness, knowing your own emotions, strengths, weaknesses, triggers. Self-regulation, managing your impulses, controlling disruptive emotions. Motivation, having an inner drive to achieve, being optimistic, resilient. Empathy, understanding others' feelings, perspectives, taking an active interest in their concerns. And social skills, managing relationships, building networks, communicating effectively, influencing others.
Those all sound like really valuable life skills. How do you measure EI?
Couple of ways. Self-report questionnaires are common where you rate yourself on different EI skills, like the EQI. These are subjective, though.
Right.
There are also performance-based tests like the MSCEI, where you solve emotion-related problems. These aim to be more objective measures of your actual ability.
Interesting. What does high EI look like in a person? What are the signs?
People with high EI tend to understand what triggers their emotions. They're generally empathetic, they can stay relatively calm under pressure, they build strong relationships, communicate clearly, adapt well to change, are usually pretty motivated from within.
And low EI, what are those signs?
Low EI might look like poor self-awareness, not knowing why they feel or act a certain way, being impulsive, lacking empathy, maybe seeming insensitive or dismissive. Poor social skills, awkward interactions, trouble resolving conflict, avoiding feedback, misreading social cues, blaming others for their problems.
Big difference in effectiveness there. What shapes our EI? Is it fixed?
No, not fixed. It's influenced by a mix of things.
Right.
Genetics and personality play a role. Early childhood experiences, how emotions were handled in the family. Social and cultural norms around expressing emotion. Education and specific EI training can boost it.
Right.
Mental health conditions can impact it. High stress or trauma can definitely affect your ability to regulate emotions.
So it can be developed. How can someone improve their EI?
Absolutely, it takes conscious effort. Self-reflection is key, paying attention to your feelings and reactions. Practicing active listening to really understand others. Asking for feedback on how you come across. Deliberately trying to see things from others' perspectives to build empathy. Expanding your emotional vocabulary, being able to name feelings accurately. Learning techniques to manage impulses and stress. Specific EI training programs can also help.
That's really hopeful. Can EI also get worse?
Yes, unfortunately.
Yeah.
Chronic stress or burnout can deplete your emotional resources. Unaddressed mental health problems can interfere with emotional regulation and perception. Being in consistently negative or unsupportive social environments. Substance use can impair emotional processing. Isolation, too.
So it needs ongoing attention. Can you give quick examples contrasting high versus low EI for those 5 components?
Sure. Self-awareness. High EI, I know I get defensive when criticized. Low EI, it's not my fault, they're just attacking me.
Okay.
Self-regulation. High EI takes a deep breath before responding angrily. Low EI explodes or shuts down immediately. Motivation. High EI stays optimistic and keeps trying after a setback. Low EI gives up easily, gets discouraged quickly. Empathy. High EI notices a colleague seems stressed and asks if they're okay. Low EI, oblivious to others' feelings or dismisses them.
Got it.
Social skills. High EI navigates disagreements constructively, finds common ground. Low EI argues, escalates conflict, or avoids difficult conversations altogether.
Those examples really clarify it. Wow, this has been incredibly comprehensive, covering so much vital ground on mental health, illness, treatment, and EI. Thank you.
My pleasure. It's important stuff to talk about.
Absolutely. So for everyone listening, we've journeyed through a really complex landscape today. The big takeaway: mental health isn't static. It's this dynamic continuum. It's shaped by this intricate mixed biology, psychology, our social world, our culture.
Right. And building resilience, understanding cultural perspectives, these are so important for prevention and recovery.
And developing your emotional intelligence gives you practical tools, really, for navigating your own inner life and how you connect with others. Okay, so here's a final thought to leave you with. Considering this complex interplay of nature, nurture, culture, society that we've explored, what single fundamental shift in how we understand or approach mental well-being do you think would create the most significant positive impact, both for individuals and for our communities as a whole? Something to mull over.